Hyperparathyroidism is an endocrine disease. Look at this picture, shows that parathyroid gland ultrasound finding. Look at this. Skin, muscles, thyroid gland, and parathyroid. A detail going on. Introduction. Hyperparathyroidism is a condition characterized by the overactivity of one or more of the parathyroid glands, resulting in excessive production of parathyroid hormone PTH. This hormone plays a critical role in regulating calcium, phosphorus, and vitamin D levels in the blood and bones. Hyperparathyroidism can lead to a range of systemic effects impacting bones, kidneys, and overall metabolic health. Etymology. The term hyperparathyroidism originates from the Greek prefix hyper, meaning over or excessive, and parathyroid, referring to the small glands located besides the thyroid gland. Combined with the suffix ism, it denotes a condition characterized by excessive activity of the parathyroid glands. Definition. Hyperparathyroidism is a condition where in the parathyroid glands produce excess parathyroid hormone PTH, leading to hypercalcemia, elevated calcium level in the blood, and associated metabolic disturbances. Types. 1. Primary hyperthyroidism caused by a problem with in the parathyroid glands such as adenoma, hyperplasia, or carcinoma. Second, secondary hyperparathyroidism, a compensatory response to chronic hypocalcemia, often due to vitamin D deficiency, chronic kidney disease, or malabsorption syndromes. 3. Tertiary hyperparathyroidism. Persistent hyperthyroidism affects prolonged secondary hyperthyroidism, often seen in patients with kidney failure who undergo dialysis. Causes. 1. Primary hyperthyroidism caused by parathyroid adenoma, parathyroid hyperplasia, parathyroid carcinoma, or genetic disorders like MEN1, multiple endocrine neoplasia type 1. 2. Secondary hyperparathyroidism, chronic kidney disease, severe vitamin D deficiency, or gastrointestinal malabsorption, example celiac disease. 3. Tertiary hyperthyroidism, chronic stimulation of parathyroid glands due to long standing secondary hyperparathyroidism. Risk factors: 1. Female gender, especially post menopausal women. 2. Age, commonly affect individuals over 50 years age. 3. Family history of parathyroid disorders. 4. Chronic kidney disease or dialysis. 5. Prolonged vitamin D deficiency. 6. Genetic predisposition, example MEN syndromes. Complications: 1. Osteoporosis and bone fractures. 2. Kidney stones. 3. Calcifications in soft tissues. 4. Peptic ulcers and gastrointestinal disturbances. 5. Cardiovascular issues, hypertension, arrhythmias. 6. Neuropsychiatric disturbances, including depression, confusion, fatigue. Pathophysiology: hyperparathyroidism leads to excessive secretion of PTH, which bone affects, increases bone reabsorption, leading to osteoporosis and bone pain. Kidney effects: enhance calcium reabsorption and phosphate excretion, causing hypercalcemia and hypophosphatemia. Intestinal effects: stimulates increased calcium absorption via activation of vitamin D. Hyperparathyroidism involves excessive secretion of parathyroid hormones due to overactivity parathyroid glands. Here is a detailed step-by-step breakdown of the process. 1. Stimulates for excessive PTH production in primary hyperthyroidism. A parathyroid adenoma, hyperplasia, or carcinoma causes unregulated overproduction of PTH. In secondary hyperparathyroidism, chronic hypocalcemia, low blood calcium level due to kidney disease, vitamin D deficiency or malabsorption disorders stimulates parathyroid glands to produce more PTH. In tertiary hyperparathyroidism, prolonged secondary hyperparathyroidism causes autonomous PTH secretion. 2. Increased PTH release. 3. Action of excess PTH target organs. A. Bones, B. Kidneys, C. Intestines. 4. Hypercalcemia. 5. Systemic effects of hypercalcemia. A. Effects on nerve system, B. Muscles, C. Kidneys, D. Cardiovascular system, E. Gastrointestinal system. 6. Progression to complications. Without treatment, chronic PTH, overproduction and hypercalcemia can result in severe osteoporosis, fractures, and skeletal deformities. Chronic kidney disease or failure due to long-term nephrocalcinosis, cardiovascular complications including arterial calcification and hypertension. Understanding this step-by-step pathophysiology is crucial for managing and treating the condition effectively. Signs and symptoms. 1. Skeletal, bone pain, fractures and deformities. 2. Renal, kidney stones, polyuria and nephrocalcinosis. 3. Neurological, fatigue, depression, confusion, memory loss and muscle weakness. 4. Gastrointestinal, nausea, vomiting, constipation and abdominal pain, cardiovascular, hypertension and arrhythmias. Diagnosis. 1. Blood test, elevated calcium level, hypercalcemia, increased PTH level, low or normal phosphate levels. 2. Imaging studies. A. Ultrasound or system-AB scan for parathyroid localization. B. Bone densitometry DXA scan for osteoporosis. 3. Urine test, 24 hours urinary calcium excretion. 4. Other kidney function test, vitamin D levels. Nursing diagnosis. 1. Risk for injury related to weakened bones and potential fractures. 2. Impaired urinary elimination related to kidney stones. 3. Acute pain related to bone fractures or renal colic. 4. Imbalanced nutrition less than body requirements related to nausea and poor appetite. 5. Risk for activity intolerance related to fatigue and muscle weakness. Management. First, medical management. 1. Medications. Bisphosphate for bone density preservation. Calcimimetitis, example cinacalcilate to lower PTH secretion. Then vitamin D supplements. 2. Surgical intervention, parathyroidectomy, removal of affected parathyroid glands. 3. Dialysis for severe cases in chronic kidney disease. 4. Hydration to prevent kidney stones. Nursing management. 1. Monitor calcium levels. Regular blood test to track calcium and PTH levels. 2. Pain management. Administer prescribed analgesics and provide comfort measures. 3. Fall prevention. Educate or safety measures to avoid fractures. 4. Dietary counseling. Promote a balanced diet with adequate hydration. 5. Psychosocial support. Address anxiety and depression. Treatment options. 1. Surgical parathyroidectomy for primary hyperparathyroidism. 2. Pharmacological calcium mimetics, bisphosphonates and vitamin D analogues. 3. Lifestyle modification. Regular exercise and hydration to maintain bone and kidney health. 4. Dialysis for secondary and tertiary hyperparathyroidism due to kidney failure. Psychosocial medicine. 1. Counseling. Address anxiety, depression and stress related to chronic illness. 2. Support groups. Encourage participation in groups for individuals with similar conditions. 3. Education. Provide knowledge about the disease, treatment and lifestyle changes. 4. Cognitive behavioral therapy CBT. Help manage emotional and mental health challenges. 5. Family support. Involve family members to enhance understanding and care coordination. Prevention. 1. Adequate intake of calcium and vitamin D through diet or supplements. 2. Regular screening for at-risk individuals, example post-menopausal women, patients with kidney disease. 3. Early management of conditions like vitamin D deficiency and chronic kidney disease. 4. Avoid excessive calcium supplementation without medical advice. 5. Healthy lifestyle practices including regular exercise. In conclusion, hyperparathyroidism is a manageable condition when diagnosed early and treated appropriately. By addressing the underlying causes, employing effective treatment strategies, and providing holistic nursing care, complications can be minimized and quality of life can be improved. Prevention through education and lifestyle modification is key in reducing the incidence of this disorder. Thank you. Have a nice day.